This chapter, we're going to start talking about acid controlling drugs and the GI system. So the pathophysiology related to acid accumulation is that within the stomach secretes hydrochloric acid, bicarbonate, pepsinogen, intrinsic factor, mucus, and prostaglandins. Within the cells of the gastric gland, we have parietal cells, and they produce and secrete the hydrochloric acid. They're the primary site of action for many of the drugs that are used to treat acid-related disorders. The second group of cells are the chief cells, and they secrete pepsinogen, which is a proenzyme. Pepsinogen becomes pepsin when activated by exposure to acid. So if we didn't have the hydrochloric acid, we wouldn't have the pepsin. Pepsin breaks down proteins. It's proteolytic. And so it's important for us for the digestion of our proteins. So we don't want to get rid of all of our acid in the stomach because then we wouldn't make pepsin and then we wouldn't digest our proteins correctly. Then we have mucus secreting cells. These are in the surface epithelial cells, and they provide a protective mucus coat. They protect against the stomach digesting itself by the hydrochloric acid and digestive enzymes. After all, your stomach is a protein. So if we didn't have this mucus layer to protect it and keep the pepsin and the hydrochloric acid from acting on it, we would digest our own stomach. We also have endocrine glands there and enterochromomuffin secretion. So hydrochloric acid in the stomach is secreted by the parietal cells when it's stimulated by food, caffeine, chocolate, and alcohol. It maintains the stomach pH at about 1 to 4. Remember, the lower the number, the more acidic it is. Acidity aids in the proper digestion of food and defenses against microbial infections via the gastrointestinal tract. So if you think about it, that acid that's in your stomach is keeping whatever bacteria you're ingesting from infecting your GI system. The secretion is also stimulated by large fatty meals and emotional stress. So I would imagine that as you guys are getting closer to final exams, your stomachs are secreting more hydrochloric acid. There's a number of acid-related diseases. Peptic ulcer disease is one. We call it PUD. And this is when gastric or duodenal ulcers involve digestion of the GI mucosa by the enzyme pepsin. So in other words, we don't have that mucus layer there protecting the walls of the stomach, and so that pepsin and hydrochloric acid are digesting the stomach itself. Helicobacter pylori, or H. pylori, is a bacterium that's found in the GI tract of 90% of patients with duodenal ulcers and 70% of those with gastric ulcers. It's interesting because I was watching something just the other night about the person who discovered the H. pylori as a cause of ulcer disease. And when he first presented his findings to his GI colleagues, they literally laughed him off the stage and refused to accept his findings. And it wasn't until about the time of his death that they actually found that everything that he had been saying was true. And he won a Nobel Prize for discovering the fact that H. pylori caused ulcers. The first line therapy for H. pylori infection is a 10 to 14 day course of a proton pump inhibitor and the antibiotics clarithromycin and either amoxicillin or metronidazole in combination with the PPI, bismuth subsalicate, and the antibiotic tetracycline and metronidazole. So it doesn't mean that you're taking all of those, but in some patients, they may actually require all of the ones they're listed at the end. In addition, we can get stress-related mucosal damage. The GI lesions are a common finding in intensive care unit patients, especially within the first 24 hours after admission. So think about the fact of what's going on with a patient that's being admitted to an ICU situation. Usually there's problems involved with decreased blood flow. There may be mucosal ischemia. There may be hypoperfusion and reperfusion injury. Remember, the blood shunts away from the gastrointestinal tract when there's problems involved with the heart or the lungs or the brain, because again, the body wants to keep or in shock, because we want to keep the heart, the blood, the oxygenated blood in the heart and in the brain, and we need the lungs in there so that it's oxygenated. So it's not that the gut doesn't get any perfusion, but it has decreased perfusion or hypo perfusion. The NG tubes that we put down because they have backup or the bowel may have stopped having motility, and then the ventilators, that they all predispose patients to GI bleeding. A histamine receptor blocking drug, or a PPI, are given for prevention of stress-related mucosal damage. The data doesn't support the continued use of stress ulcer prophylaxis after the patient's no longer in the ICU, because they really feel that it's that stress, physiologic stress, not to mention that most patients in the ICU, even if they're not conscious, their brain is still aware of the noises and the fact that they're as ill as they are. The previous slide showed the 3 different types of stomach acid type drugs, and so let's start with antacids. They are basic compounds used to neutralize the stomach acid. Basically, they're salts of aluminum, magnesium, calcium, and or sodium. Many antacid preparations also contain an antiflatulent drug, simethicone. And many aluminum and calcium-based formulations also include magnesium, which not only contributes to the acid neutralizing capacity, but it also counteracts the constipating effects of aluminum and calcium. Not to mention, think about what magnesium does in the body. Magnesium causes relaxation of the muscles. So if you think about if stress is one of the causes of the hypersecretion of acid, having something that causes relaxation of the muscles is going to help with decreasing the amount of acid produced. Calcium antacids can lead to the development of kidney stones and increased gastric acid secretion, which is kind of interesting since that's what we're putting them down there to prevent. But if you ingest too much calcium, your body needs to get rid of it somehow. We think about, we it hasn't been that long since we talked about calcium in bones, but if you don't need to put that calcium into your bone and your body isn't sensing that you need additional calcium circulating in your system, it's going to get rid of it. And the way we get rid of it is through the kidneys and the excretion in the kidneys. Well, you put that much calcium into the kidneys and it's going to form stones. Antacids that contain magnesium need to be avoided in patients with renal failure. And sodium bicarbonate is a highly soluble antacid form with a quick onset but a short duration of action. So sodium bicarb is something that we often will hear older people having taken, which, by the way, for those of you that don't know, sodium bicarbonate is baking soda. So basically, these are the people that are going over and saying, oh, I'll just have a teaspoon of baking soda. That'll take care of my upset stomach. Well, if people take too much of their baking soda, their sodium bicarbonate, it's going to cause them to become alkalotic because it's so highly soluble that it'll get out into the blood system very easily. And so it's not uncommon for us to see elderly people in general coming into the ED with low respiratory rates because they've made themselves metabolically alkalotic by taking sodium bicarbonate, baking soda, for their upset stomach. When we look at the mechanism of antacids, they don't prevent the overproduction of acid, but instead they help to neutralize those secretions. They promote gastric mucosal defense mechanisms. So in other words, they promote more mucus to be produced. They also help to protect that mucosa by decreasing the acidity in the stomach. They stimulate secretions of mucus and a bicarbonate, and the bicarbonate helps to buffer the acidic properties of the hydrochloric acid. And they also stimulate secretions of prostaglandins, which prevent activation of the proton pump. And the proton pump is the result of the pepsinogen. So what happens when we take an antacid? Well, we get a reduction of pain that's associated with acid-related disorder. It raises the gastric pH 1 point, so from maybe 1.3 to 2.3, and it neutralizes 90% of the gastric acid. It reduces the acidity, and that reduces the pain because the base-mediated inhibition of the protein digesting ability of pepsin. So basically what we've done is we've made it so that the pepsin is no longer digesting the stomach. We've also increased the resistance of the stomach lining to irritation because we've decreased the acid level of the stomach secretions. And we've also increased the tone of the cardiac sphincter, which means that the reflux is not able to go up into the esophageal areas. So there are contraindications to antacids. Obviously, the known allergy to any specific drug product, severe renal failure or electrolyte disturbances may produce a potential toxic accumulation of electrolytes in the antacids themselves. Like I was just saying about the sodium bicarb, that if somebody takes too much of it, it's going to affect their pH of their blood as well. If they have GI obstruction, antacids may stimulate GI motility when that's not a good thing. And so we definitely don't want to give it to somebody that we're suspecting may have GI obstruction. Most antacids are available over the counter. They come in formulations available as capsules and tablets, powdered versions, chewable tablets, suspensions, effervescent granules and tablets. They can be used alone or in combination. So we may have aluminum and magnesium salts combined, or magnesium and calcium salts combined, or we may have bicarbonate combined with calcium, like we may have calcium bicarbonate. The aluminum salts have a constipating effect, and they're often used with magnesium to counteract the constipation. They're often recommended for patients with renal disease because they're easily excreted. And some examples of those are aluminum carbonate, hydroxide salt, or combination products like Gaviscon, Maalox, Mylanta, or G-Gel. One little piece here is that the aluminum salts, antacids, used to be used a lot more heavily than what they are now. And some of the reasons why they've gone out of failure is that there was some research done that made an association between increasing levels of aluminum in the body and Alzheimer's disease. And so the aluminum salt antacids really kind of fell out of favor. But they are still out there and they are still being used and they are very effective. The magnesium salts commonly cause diarrhea. They're usually used with other drugs to counteract this effect. So one way of thinking about these is milk of magnesia is often given to people who have constipation to get them to go. So if you were to take milk of magnesia for your upset stomach, chances are you're going to get diarrhea. They're dangerous when used for patients that have renal failure because the failing kidney can't excrete the extra magnesium, and that results in high levels of magnesium. So examples of these are hydroxide salt, which is magnesium hydroxide or milk of magnesia, a carbonate salt, which is Gaviscon, which is also a combination product, and combination products like Maalox and Mylanta. There's many different forms of the calcium salts, but the most common for antacids is calcium carbonate, which is basically chalk. And it can cause constipation and ultimately kidney stones. It's also not recommended for patients with renal disease because it can accumulate to toxic levels, and not to mention that it can cause the kidney stones as well. And if you use it for a long period of time, it may actually increase the gastric acid secretion, and they call that a hyperacidity rebound. It's often advertised as an extra source of dietary calcium, so like Tums, which are calcium carbonate. So as we've already mentioned, sodium bicarbonate is also known as baking soda, and it's highly soluble. It buffers the acidic properties of the hydrochloric acid. It has very quick onset, but it's of short duration, and it can cause metabolic alkalosis. The sodium content may cause problems with patients that have heart failure, hypertension, or renal insufficiency. So those are definitely things that you would want to check before advising somebody to take sodium bicarbonate. So our first question. A patient who has chronic renal failure wants to self-treat with an antacid for occasional heartburn. Which medication is the best choice for this patient? A magnesium-containing antacid, a calcium-containing antacid, an aluminum-containing antacid. Because of renal problems, the patient should not take antacids for this problem. Well, as we've been discussing, C, the aluminum and sodium-based antacids, are recommended for patients with renal compromise because they're more easily excreted. Both the calcium and magnesium-based antacids are more likely to accumulate to toxic levels in patients with renal disease, and they should be avoided in this patient group. As we noted earlier, often antacids may be combined with antiflatulence. Antiflatulence are used to relieve the painful symptoms associated with GI gas. Several drugs are used to bind or alter intestinal gas and are often added to antacid combination products, but the most common is simethicone. So potential adverse effects of antacids are minimal, and they depend on a compound usage. So if you overuse it, you have a risk of metabolic alkalosis. With the aluminum and calcium, you have the risk of constipation. With magnesium, you have the risk of diarrhea. With calcium, you have the risk of kidney stones and rebound hyperacidity. And with calcium carbonate, it produces gas and belching, and that's often, so because of that, it's combined with simethicone. I just wanted to point out that although simethicone helps to relieve the bloating, uncomfortable feeling of gas, just remember that until the gas is out of the body, it's still in there. Basically, what the simethicone does is to reduce the size of the gas bubbles to something that's smaller so that you don't feel as distended. And it really doesn't make the gas go away. It doesn't go away until either you burp it up or you fart it out. There's a number of drug interactions related to antacids. For example, absorption of other drugs to the antacids. It reduces the ability of the other drug to be absorbed into the body. With chelation, chelation is the binding of a drug or substance to another substance. So in this case, there's a chemical binding or inactivation of another drug because it has bound to the antacid. And that produces insoluble complexes, which in some cases is exactly what you want if it's a toxin. But it results in reduced drug absorption if it is binding to a drug that you want the patient to get. In addition, with the increased stomach pH, so in other words, the lower acidity, it will increase absorption of drugs that are more basic, and it will decrease the absorption of acidic drugs. So just remember that certain drugs are manufactured and tested based on their pH. So if I have a drug that is more basic and I'm counting on the stomach pH being around 1 to 4, and the stomach pH is only right at 4, is going to mean that that basic drug is being absorbed more because the stomach itself is basic. And if I'm counting on that acidity being in the stomach for absorption and the stomach is less acidic, then less of the drug is going to be absorbed. Also, it can cause increased urinary pH. So it will increase the excretion of acidic drugs. So, and then it will decrease the excretion of basic drugs. And again, it has to do with the balance that's there as these go through the kidney. The kidney wants to see the urine at a certain pH. And because of these changes that have happened metabolically, it can make the kidneys excrete the drugs either faster or slower. So let's look at the histamine or the H2 receptor antagonists. These reduce acid secretion. Histamine increases acid secretion, and so these are antagonists, so they're going to decrease the acid secretion. All are available in over-the-counter lower dosage forms, and the most popular drugs to treat acid-related disorders include cimetidine, which is Tagamet, nizatidine, which is Axid, famotidine, which is Pepcid, and ranitidine, which is Zantac. The way these drugs work is that they competitively block the H2 receptor for the acid-producing parietal cells, and that results in reduced hydrogen ion secretion from the parietal cells. This increases the pH in the stomach because there's not as much acid there, and that gives relief to many of the symptoms associated with hyperacidity related conditions. So obviously the drug effect is that there's suppressed acid secretion in the stomach. The indications are things like gastroesophageal reflux disease, peptic ulcer disease, erosive esophagitis, and adjunct therapy to control upper GI bleeding, and Zollinger-Ellison syndrome. Not to mention also the stress ulcer treatment for ICU patients. When we look at potential adverse effects, overall there's very few. Otherwise, they wouldn't be over the counter. However, there's central nervous adverse effects in elderly patients that include confusion and disorientation. Cimetidine may induce impotence and gynecomastia in some male patients, and thrombocytopenia has been reported with ranitidine and famotidine. Of course, there's always drug interactions. With cimetidine or Tagamet, it binds with the P450 microsomal oxidase system in the liver, and that results in inhibited oxidation of many drugs and increased drug levels. So in other words, because it binds with that system, it makes it so that that system isn't able to break down other drugs, and so those drugs will have higher levels than what you would expect. So they may, if somebody is taking this regularly, they may need to adjust the dosages of those medications. All H2 antagonists may inhibit the absorption of drugs that require an acidic GI environment for absorption. And because of its potential to cause drug interactions, cimetidine has been largely replaced by ranitidine and famotidine. Cimetidine is still used to use certain allergic reactions. Smoking has been shown to decrease the effectiveness of H2 blockers. And for optimal results, H2 receptor antagonists are taken 1 to 2 hours before antacids. And here's another question. When working with an older patient who has been admitted for a possible GI bleed, the nurse identifies which drug is having the potential to cause confusion and disorientation. Well, that would be our H2 antagonists because they may cause confusion and disorientation in older adults. Proton pump inhibitors are relatively new within the last 20 years. The parietal cells release the positive hydrogen ions, or the protons, during HCl production. This process is called the proton pump. So the H2 blockers and the antihistamines do not stop the action of the pump, where the proton pump inhibitors actually stop that. So with the antihistamines or the H2 blockers, they actually stop the histamines from getting the pump going, where in this case it actually acts on the parietal cells themselves or the pump. And so that's what we're looking at here. Lansoprazole, omeprazole, rapamycin, pantoprazole, and esomeprazole are the most common proton pump inhibitors. And as you can see by their brand names, these are things that we see a lot of commercials for on TV. The mechanism of action with proton pump inhibitors is that they irreversibly bind to the hydrogen and the potassium ATPase enzyme. So in other words, they don't break down the ATP. This bond prevents the movement of hydrogen ions from the parietal cells into the stomach. It results in achlorhydria, meaning that all gastric acid secretion is temporarily blocked. To return to normal acid secretion, the parietal cell must now synthesize new hydrogen and potassium ATPase. The indications for proton pump inhibitors include GERD, or gastroesophageal reflux disease, esophageal erosive esophagitis, short-term treatment of active duodenal and benign gastric ulcers, Zollinger-Ellison syndrome, nonsteroidal anti-inflammatory induced ulcers, stress ulcer prophylaxis, and the treatment of H. pylori induced ulcers when given with an antibiotic. Again, when looking at adverse effects, the proton pump inhibitors are generally well tolerated, or otherwise they wouldn't have allowed them to go over the counter. However, if you have a possible predisposition to GI tract infections like with Clostridium, that would be it may be encouraged by the proton pump inhibitors. There is some effect of osteoporosis and the risk of wrist, hip, and spine fractures if it's used for a long period of time. Pneumonia and depletion of magnesium is also associated with the use of proton pump inhibitors. Like anything else, we have to worry about drug interactions. There's increased serum levels of diazepam and phenytoin associated with the use of proton pump inhibitors. With warfarin, we have increased chance of bleeding. So in other words, the warfarin is not going to work, or is going to work better than what we want it to work. The absorption of ketonosol, ampicillin, iron salts, and digoxin are decreased with it. Clopidogrel is affected by it. Sucralfate the use of it with sucralfate may delay the absorption of the PPIs, and food may also decrease absorption of the PPIs. Sucralfate or carafate is a cytoprotective drug. It's used for stress ulcers and peptic ulcer disease. It's attracted to and binds to the base of ulcers and erosions, and it forms a protective barrier over those areas. It protects the areas from the pepsin, which would normally break down the proteins, making the ulcers worse. There's little absorption of sucralfate from the gut. It may cause constipation, nausea, and dry mouth. It may also impair the absorption of other drugs, so you need to give the other drugs at least 2 hours before the sucralfate. You do not want to administer with other meds for that reason, and it binds with phosphate, so it may be used in chronic renal failure to reduce phosphate levels. When teaching a patient about sucralfate therapy, which of the following statements will the nurse include? Take sucralfate 1 hour before your other medications. Sucralfate is administered once daily upon waking up. Sucralfate acts systemically to heal gastric ulcers. Sucralfate binds and concentrates epidermal growth factor to promote ulcer healing. So the answer is sucralfate binds and concentrates epidermal growth factor to promote ulcer healing. The other answers are wrong because it doesn't act systemically, it's administered more than once daily, and you need to take the medications 2 hours before you take the sucralfate. Misoprostol or Cytotec is a prostaglandin E analog. Prostaglandins have cytoprotective activity. They protect the gastric mucosa from injury by enhancing local production of mucus or bicarbonate, and it promotes local cell regeneration. It also helps to maintain mucosal blood flow. It's used for prevention of NSAID-induced gastric ulcers. Doses that are therapeutic enough to treat duodenal ulcers often produce abdominal cramps and diarrhea. As we mentioned before, simethicone is an anti-flatulent drug, and it's used to reduce the discomforts of gastric or intestinal gas or flatulence. It alters the elasticity of the mucus-coated gas bubbles, breaking them into smaller ones, and the result is decreased gas pains and increased expulsion either by a burp or a fart so that you get the gas out of that person. Simethicone or Milacon is often combined with calcium carbonate antacids because A, an increased antacid effect will result when these drugs are given in combination, or B, simethicone helps to reduce the gas that's caused by the calcium antacids, or C, simethicone reduces the diarrhea that's caused by calcium, or D, simethicone improves the taste of the calcium tablets which must be chewed. Well, the answer is B. The calcium carbonate neutralization will cause gas and possible belching, so the addition of simethicone is intended to reduce that effect. So what are our nursing implications? We want to assess for allergies and pre-existing conditions that may restrict the use of antacids, things like fluid imbalances, renal disease, GI obstruction, heart failure, or pregnancy. Patients with heart failure or hypertension should not use antacids that have high sodium content. We want to use caution with other medications because of the many drug interactions. Most medications should be administered 1 to 2 hours after an antacid. Antacids may cause premature dissolving of enteric coating medications, resulting in stomach upset. Be sure that chewable tablets are chewed thoroughly and liquid forms are shaken well before giving. Antacids have a tendency to form a really solid layer on the bottom. Again, think about the fact that um, calcium carbonate is chalk. And so they don't stay in solution real well, and they make this chalky muck on the bottom of the liquid forms. You want to administer with at least 8 ounces of water to enhance absorption, except for the rapid dissolve forms. Long-term self-medication with antacids may mask symptoms of serious underlying diseases like a malignancy or bleeding ulcers. And so you want to find out when you're doing your assessment on patients, how long have they been taking antacids? Because as we ask them and say, what over-the-counter drugs do you take? They may tell you that they take Tums every night. Well, how long have they been taking Tums every night? If symptoms remain ongoing, the patient should seek medical evaluation. We want to monitor for adverse effects like nausea, vomiting, abdominal pain, and diarrhea. And with calcium-containing products, we want to monitor for constipation and acid rebound. We also want to monitor for the therapeutic response. And we should educate our patient to notify the healthcare provider if the symptoms are not relieved. The nursing implications specific with H2 antagonists and proton pump inhibitors include assessing for allergies and impaired renal or liver function. Use with caution in patients who are confused, disoriented, or older, as that may become worse. You want to take the medication 1 to 2 hours before antacids are given. And for intravenous doses, you want to make sure you follow administration guidelines. You're going to assess for allergies and a history of liver disease, and not all are available for parenteral administration. So if someone's been receiving this as an oral medication and now they're NPO, we may need to change to a different medication because their medication may not be available as a IV dose. We may also increase the serum levels of diazepam and phenytoin, and it may increase the chance of bleeding with warfarin. The granules of pantoprazole capsules may be given via NG tubes, but the NG tube must be at least a 16 gauge or the tube may become clogged. Capsule contents may be opened and mixed with apple juice, but do not chew or crush delayed release granules. And finally, when providing education regarding the use of PPIs, which statement will the nurse include? Take medication along with the first meal of the day. Take the medication on an empty stomach 30 to 60 minutes before eating. C. Take the medication when you have symptoms of heartburn. D. Take the medication at bedtime with a snack. Well, the correct answer is B. Food may decrease the absorption of PPIs, and it is recommended that they be taken on an empty stomach. They are taken on a daily basis, not as needed for heartburn. Many people misunderstand this, and it's really important to reinforce this to patients, is that these PPIs usually don't start working on the first day. So they're not like an antacid where you take the antacid and they start working right away. And even the H2 receptor medications start working in a short period of time. But PPIs have to build up in the system. And so they normally take several days to a week before patients start having relief from the administration of the PPIs.